General of Indian Council of Medical Research. Her expertise and contributions include uh, her contributions in global issues in tuberculosis and HIV research. She's also a renowned pediatrician. She played a key role in integrating science into health policy making in India as well as in other countries. And academically, she has contributed close to 500 peer-reviewed articles in top journals. It's a really a remarkable achievement. And other engagements of Dr. Swaminathan include as a she acts as a co-chairs. Uh, she co-chairs a global commission on our common air initiative and serves on the Kofi Annan Commission on Food Security and board member of the Alliance for Biodiversity. And her notable contribution include, uh, as I said earlier, as a chief scientist in WHO, during the COVID-19 pandemic, Dr. Soumya Swaminathan was a symbol of hope, guiding the world with science, clarity, and compassion in those uncertain times. We remember during that time, whenever we look at what she says in the TV about the COVID case and how they are managing the situation. She was a key figure in coordinating global vaccine distribution through COVAX during COVID-19. And her current areas of research focus include addressing health impacts of climate change, particularly on women and children, and strengthening nutrition security and health transformation in India. So, with this, I invite Dr. Swaminathan to deliver this lecture on universal health coverage in India, a continuing journey. And I understand that this topic is very close to the heart of uh, PG Kumar during his time. He had a lot of interest on this topic. So we have the right person to speak on this occasion. Dr. Swaminathan.
Thank you. Thank you very much, Dr. Veeramani. It's indeed a great pleasure and honor to be here. Everyone has heard about CDS, but it's actually my first opportunity to visit. And I had a quick walk around the campus, and it's very, very beautiful. So it's really nice to be here this afternoon. Um, and also a privilege to be giving this lecture. And I saw that the previous speakers have all been extremely eminent people, including Professor Amartya Sen. I think Gopu Kumar was his student, and I understand he gave the first memorial lecture. So obviously, we lost him at a very young age, but even in that short time, I think he had, really done a lot of work on, especially around ethics and equity. So we can, I think it's a small enough group that we can keep it informal and hopefully have some discussion at the end. I will touch upon a little bit on the historical journey of universal health coverage and where we are today, but also take tuberculosis as an example of a disease which is still a huge challenge and a burden in India. And we need to think of ways of really addressing it. And then go on to talk a little bit uh, about the challenges that are facing India and Kerala in particular, in terms of how the health system really needs to look at reorienting itself, given that the challenges are also changing. So these are the main broad headings under which I will speak. So starting with the determinants of health, one of the things, of course, that we often forget, even when we use the term universal health coverage, the typical picture is of providing health services to everyone. And of course, that's a very important element of universal health coverage. But uh, health is not only about services. And so the determinants of health, which you can see here on the left hand side, obviously genetics plays a role, but even more important than genetics would be the environment, what we call the social, economic, environmental determinants, education, housing, access to basic services, the social and community context, of course, what rights people enjoy, income stability. So, in fact, 70 or more percentage of one's health is determined by that, and only 20 to 30% is determined by the actual access to health services. So, while that is equally important, we often tend to include these other factors when we talk about health. I think I don't need to explain to this audience the difference between equality and equity. But very often, I think people confuse these terms. I think this graphic very clearly shows what is the difference. No? Equality is you give everyone the same stool, the stool has the same height. So people who are already privileged will have a will continue to have that advantage. Equity, on the other hand, is when you give the person who's the shortest in this case or the weakest the tallest stool to stand on, and thereby you're equalizing the opportunities for all of them to have a fair chance. So the word equity we use quite often, but I think really understanding what it is and how do we actually give that additional support, and how do we start with a lens of equity when we're talking about particularly about social services like health coverage or education and so on. So there are many factors that determine universal health coverage. Political is very important. The politics and the political economy clearly plays a very big role. Of course, economics is important, the governance of it, the socio-demography, epidemiology, and what are the values that are assigned. Now, politics today we see globally, every day we see headlines about what is happening in geopolitics. And particularly recently, these cuts that have been made by the US in aid, particularly the USAID, that was a very major supporter of HIV, TB, malaria programs, also immunization, um, many things, surveillance, um, capacity building of laboratories, through the CDC, global programs. All of that has now suddenly been cut abruptly. And so we're going to see for sure a uh, backward slide, I think, in many of the health indicators that we have been tracking, the SDGs, including HIV infections, new infections, HIV control, prevention of mother to child transmission, immunization rates, TB, multi drug resistant TB. Of course, US was also a biggest supporter for the global polio eradication program. As you know, polio is only remaining in two countries now, Pakistan and Afghanistan. The world is very, very close to eradication. But again, because of conflict and displacement in the last couple of years, the wild polio cases has actually gone up. At one time, I think it was 2020 or 21, we had come down to 6 cases only in the whole world. And now it's back, I don't know, to 60 or 70. Similarly, the values, the political economy, the kind of um, other beliefs there are in society. We know that in some African countries like Uganda, there are even now anti-gay laws. People are murdered or they're put into jail and things like that. So, what is it that you prioritize? What does a country prioritize? During COVID, the Tanzanian president announced that COVID did not enter Tanzania, basically, that there was no COVID in Tanzania. People should go about their normal lives and do everything normally, and refused to even allow vaccinations to enter the country. That president then died of COVID. But by then, of course, a lot of other Tanzanians had also died. And then the new president who was appointed, a woman, she then started the vaccination program. And so it makes a big difference, actually, what kind of leadership you have. The other thing to think about, of course, is that these intertwined and in some cases escalating global threats. So you can see that in red you have the geopolitical threats like societal polarization, erosion of human rights, involuntary migration, unemployment, and so on. In blue, you have the economic threats, the economic downturn, the disruptions to infrastructure, partly also because of climate change and the hazards, increasing number of weather events that we are seeing, inflation. Then in green, you have the environmental threats, and these are actually growing in size. Every year, we see the environmental threats like the biodiversity collapse, pollution, the planetary boundaries, what are called the 9 planetary boundaries. 6 of them have already been breached. And as you know, the IPCC reports, really paint a very worrying picture. Today, we are already on the cusp of 1.5 degrees warming over and above the pre-industrial era. And then you have the technological threats here in purple. That is your misinformation, disinformation, the cyber insecurity, the adverse outcomes of AI technologies, all the deep fakes that you see today on social media. You really can't tell which one is a deep fake and which one is a true. So any one of us, could be saying anything on social media and we would never have said it. So that's the kind of technology today we're dealing with. So all frontier technologies have a lot of benefits, of course, and we want to harness those benefits, but they also have these immense risks which need to be better understood and handled. Particularly, I'm talking from a public health point of view, because again, during COVID, we saw amount of misinformation around vaccines that was spread, as well as on many other technologies. Today, you're seeing measles outbreaks in the United States because the trust in vaccines has gone down so much because of disinformation. So that's the global context. And obviously, public health is placed within this context. And then you have the conflicts as well, multiple conflicts which are happening. So, the 3 C's, people often used to talk about COVID, climate change, and conflict. And while COVID may have, reduced in terms of its threat, the other two are very much there. Now, that's a demographic overview. I think everybody is familiar because we have a very large urban population growing, and about half of our urban population lives in slums. In terms of our rights, enshrined in the Constitution, the right to life and the right to health are there in Article 21. But of course, we also have these three lists in which allocate the powers and functions. And so on the union list, you have some of the medical research institutions, AIMS, NIPERS, but also quarantine and, the dealing with UN agencies and all that comes there. In the current list, you have things like population control, family planning, drugs, medical education, and control of medical profession, social security. And then in the state list, you get public health, sanitation, hospitals, but also animals, diseases, water, fisheries, and so on. So this, of course, has in a federal framework, this has advantages and disadvantages. In a large country like India, you definitely need the states to be in charge of many things because you have to deliver services to your based on the context. But it could make it challenging sometimes when you have uh, things which are in the state list. And for example, in the case of a pandemic, you definitely need some kind of coordination at the central level. So I don't know if you can see, but the journey of India's health, of course, started, from the way back in the British days. In fact, Kerala has even longer history of public health, thanks to the royal family and some of the very enlightened women from the Travancore family who actually started smallpox vaccination, way back in the 19th century, and then many other public health initiatives before there was any kind of a national public health program. The ICMR, for example, was started in 1911, way before independence. It was called the Indian Research um, IRFA. I can't remember what it was called. Anyway, it became ICMR later. Then, of course, in 1946, we had the board committee, which was the blueprint for the primary health care that's been delivered afterwards by successive governments. And then in the constitution, as we just saw, we saw the right to life and the right to health. Family planning program was one of the early ones, 1952, followed by the malaria program in 1953, leprosy 55, and so on. The first AIMS was established under the AIMS Act 1956. And then we had some early public health programs like the salt fortification program with iodine 1962. Dr. Ramalinga Swami had a lot to do with the association between goiter and iodine deficiency and mental retardation or cretinism. National TB program also started in 1962, blindness control in 76, and so on. Of course, in 78, we had the Alma Ata Global Declaration on Primary Healthcare. India was one of the signatories. And then we have our first National Health Policy in 1983. This did talk about bottom up planning involving the community. So it has been in there, but how much it was operationalized is the question. Then we had the Millennium Development Goals, 2000 to 2015. And then the National Health Policy was revised in 2002. And at that time, the role and regulation of private sector was considered, also involving NGOs and focusing on inequity. Then the big one in 2005, the National Health Mission was conceptualized. This was a fairly big change. And that's when the Ashas were brought in as the very, very front line. And even the name Asha, that is accredited social health activist, was quite, visionary in the sense that they were really considered health activists on the ground, not just delivering services. And they were volunteers, of course, being paid some incentives, but not government employees. And from there onwards, the National Health, it was initially called the National Rural Health Mission. Then there was an urban mission. Anyway, they're merged into the NHM. Sustainable Development Goals in 2015. And then the National Health Policy was again revised in 2017, this time, for the first time, talking about non communicable diseases, talking about universal health coverage and increase in the government expenditure and financing of healthcare. In 2018, the whole program was rebranded as Ayushman Bharat, which basically has two components. It has the primary healthcare component, strengthening of primary healthcare, and it has the insurance component, which was new. So 5 lakhs insurance per family under PMJY for about 500 million people who qualify for that. Then you have the as more further components being added, the Ayushman Bharat digital mission and the Ayushman Bharat infrastructure mission. These came up actually after COVID, because I think the importance of digital technologies and remote technologies became very clear during COVID, and also the need for infrastructure. So these two missions were launched in 2022. Yeah. So as I was mentioning, this is, I think, from maybe the 1920s or 30s. This is a van. It says public Travancore Public Health Education, and it's going around actually with a loudspeaker. You can see they also had other educational materials, and they're going into communities and providing. So that means Kerala already thought about prevention and promotion in those days, health promotion. So if you really look at the National Health Mission, you can see that there are many programmatic areas, both maternal child health, communicable, but also non-communicable. And an important component there is a health system strengthening and also free drugs and diagnostics. So good supply chains, essential drugs, essential diagnostics to be made available, urban health, and also they talk about community participation and health governance. The benefits, of course, is that strengthening the system in terms of HR, supply chains, infrastructure, data systems. Minimum services and commodities are provided. The financing is center state ratio of 60 to 40, but there's also some condition that's a little bit higher for Northeast and aspirational districts, and conditionality based funding, 10% for you can get extra for, there's some space for state led innovation. And you can see the Ashas. The Ashas of India actually won the WHO's Public Service Award in 2022, and there are about 1 million of them. Now, as I mentioned, in 2017, the focus a little bit changed to non-communicable diseases, also private sector involvement, looking at catastrophic expenditures and so on. And if you see some of the targets that were set at that time in our status today, we can see that we've made progress, except government health expenditure was supposed to go to 2.5% of GDP by 2025. We are not there. We're around 1.7 or 1.8%, or maybe just under 2%. So government spending on health has not gone up to the amount that it was supposed to. And catastrophic expenditure, this is again something that we don't measure very well. I think this may be of interest to people here, but we don't have a very good, there are some figures that are put out, but really no very good research studies. If you look even at TB, we know that there's a huge amount of out of pocket and catastrophic expenditures because households with TB are already poor. They end up spending so much before they can get a diagnosis, even though TB diagnosis and TB treatment are free in the government. We've done very well on reducing our fertility rates, and fairly well also on infant mortality and maternal mortality and things like that. TB cure rates, we are doing okay, though we have not really made much of a dent on the burden of TB. And then we have done well in institutional deliveries. Stunting is something we have not done so well. Right at the bottom, you can see we were supposed to reduce stunting by 40%, but it's barely gone down. In the last NFHS, it was still around 34. We'll see now this next NFHS, uh, how much stunting. And even states like Kerala still have significant percentage of stunting, even though otherwise its indicators are so good. So as I mentioned, you have the primary care strengthening as part of this Ayushman Bharat, and then you have the secondary and tertiary care, which are provided both in private and public hospitals. Primary care is mainly through the public system, and this is where your insurance package comes in. About 1,900 procedures. So mainly surgical procedures are covered, so that at least families don't have to end up spending for that, but also some inpatient care, including oral health and elderly palliative care. These are all coming up now. The team at the Health and Wellness Center. So the Health and Wellness Center is the new focus of primary care delivery. So under the primary health center, you will have 4 or 5 health and wellness centers, each catering to about 5,000 people. You have one CHO, the community health officer, who is a mid-level care provider, one multi-purpose workers, 2 ANMs, and 5 ASHAs. So that's the team that uh, is responsible for about 5,000 population. This is the tertiary care scheme, as I mentioned, the insurance scheme. And of course, the expenditure has been going up. And recently the government announced that all people over the age of 70 will also be covered with this 5 lakh annual coverage, regardless of socioeconomic status. So this is going to increase this burden on the exchequer because of insurance. We also have to remember that in India, we have healthcare which is dominated by the private sector. This includes Kerala as well. We're also the world's pharmacy. So, of course, we pride ourselves that we're a 4th largest employer in India. Value has been growing. We are in the top 3 global manufacturers of pharma and the top generics manufacturer globally. And we have a diverse ecosystem from one-room clinics, unqualified providers, very poor quality labs, all the way to the multi-speciality corporate chains, which provide very good care and offer medical tourism, but of course are very, very expensive. Now, private doctors and hospitals are concentrated in tier 1 and metro. So if you can see the share of public and private here, you can see that is going up. Private is 73%. And particularly when it comes to outpatient care, a lot of it is delivered by private provider. Inpatient care more by government. But even there, you can see that in the urban areas, um, a large proportion of it is provided by private, and it's only in rural areas where you don't have that many private that the public becomes the only uh, source of healthcare. So quality, access, equity. You can see here the total health expenditure as a share of GDP. So the US here, of course, spends a lot but doesn't get the health outcomes for the amount. They spend 17 or 18% of GDP. BRICS, Brazil, 5.4%, South Africa, 3.3. The average for low middle income countries is 2.6. We are still under 2. And of course, sub-Saharan Africa and all is lower. And similarly, if you look at total health expenditure per capita, we are spending about $74. China and Brazil are spending around $700, per person. So it is quite low. And like I said, according to the WHO, there are 55 million people who are slipping below the poverty line every year because of catastrophic expenditure on health. Also, when you look at what is spent on primary versus secondary or tertiary, actually the difference, if you see between 2019 and 22, the expenditure on tertiary has gone up. We see how many new hospitals and things are being built. Slight reduction in primary care outflow. And again, you see here, again showing that the other BRICS countries are spending a larger proportion of their GDP compared to India, which has more or less been around 2%, it has 2 to 3%. But we have, scored some successes for sure. So we've reduced our DALYs, which is a disability adjusted life years. We've eliminated a number of these diseases, and we are very close to some of these. Colors are filariasis, measles, rubella, and leprosy. Now, when I was in ICMR in 2016, for the first time, we released a report called the State Level Disease Burden Estimation. And you can see that Dr. Srinath Reddy is here. This was done at ICMR and Public Health Foundation of India with IHME. And what we showed was that this was the burden of disease in 1990, where you can see in red the communicable diseases, blue was non-communicable. It had reversed in 2016. And the share of injuries is in green. That's increased a little bit. But more than that, for every state, we had a profile of contribution of the major disease groups to deaths and disabilities. This was for the first time that states could actually see how they were different from each other. UP's profile very different from Tamil Nadu. Rajasthan very different from Kerala. So one kind of national programming when you're dealing with such, and Kerala, for example, had already made the epidemiological transition in the 80s when non-communicable diseases overtook communicable, but the country as a whole was focused still on communicable diseases, on nutrition. So and globally also was the same. It wasn't just in India. So I think there was a couple of decades where we were not seeing that invisibly diabetes, hypertension, all these were becoming more important. So ICMR has continued to do this exercise by thematic area like neurological diseases, heart, and things like that. And you can see that the same thing, 1990s to 2021 ranking, the things in blue are the non-communicable. So you can see much more blue here, and pink is infectious diseases. It's gone down, except that TB still continues to respiratory infections and TB are still high, and also gastrointestinal infections and maternal and newborn conditions. The rest of it is cardiovascular, cancer, diabetes, digestive diseases. This is taken from a study called the INDIAB study. It's funded by the ICMR, which took a long time to do because it was a countrywide study. But basically, what it shows here is the burden of diabetes and pre-diabetes. This is urban, and this this graph is of diabetes, and pre-diabetes graph would look a little bit different. But essentially, what it shows is urban areas. Look at urban areas. Almost the whole country is having a prevalence of diabetes above 10%. In rural areas, it's slightly less. But again, when you look at states like Kerala, Tamil Nadu, Punjab, Haryana, you'll find it's very high. UP still showing a low rate here, but if you look at the pre-diabetes map, you'll find that that is already red, which means all those people have developed pre-diabetes. They're just waiting over a period of time, they'll become diabetic. This obviously um, is a is a national epidemic. It results in a loss of quality of life, increased out-of-pocket expenditure, increased cost to patients, and majority of people don't know that they have diabetes or hypertension. Moreover, also our age profile is changing. So from a bulge here in the younger age group, by 2100, we're going to be like this, like what the European countries and all are now, where we'll have many more people above the age of 65. So we have a very short window of what we call as a demographic dividend. And we have to get prepared for the care of the elderly. And I think states like Kerala are already obviously thinking about this because you already are ahead of other states in this journey. Now, people can either not have access to healthcare, or you can have access but not of quality healthcare services. And there was a study that showed that more Indians died of poor quality healthcare, 2.4 million, as opposed to about out of our total mortality for about 10 million a year, as opposed to about maybe 1.5 to 1.8 million who died because they could not have access, or they couldn't reach a health center. And again, you can see wide disparities between districts. So that's one of our challenges, is we have a lot of heterogeneity, whether you look at anemia, you look at blood sugar, you look at stunting, you'll find that there are pockets which have very high prevalence. There are still some gender inequities, whether you look at age specific death rates being higher in females than in men, uh, or you look at mobile phone usage. Of course, Kerala is right here with 81 and 86% of mobile phone usage. So very close gender gap, but you can see other states where there is quite a big gender gap. So in many rural parts of the country, there may be one mobile phone in the family. It's usually held by the man of the family. Let me shift to say a little bit about TB now, because that's something I've worked on for a long time. So, as you know, we have this very high level political commitment to achieve TB elimination ahead of targets. And you can see that in 2017, so the incidence rate is calculated, it's modeled, it's not directly measured. So from 2015 to 2023, we did make progress. We reduced our incidence rate around 195 now per 100,000. But our target was this. So obviously, we're not close to that target. Similarly, mortality, which is to me more important, we have made progress in reducing TB deaths But here was our target, and we are around 21 now per 100,000. And this catastrophic expenditure, we really don't have a clue. We were supposed to go to 0% by 25. And there are some studies, of course, here it says 15%, but there are some studies showing that it is higher. So we have a challenge, and we can discuss more later. 5 major risk factors for TB in India. Undernutrition is number one, accounting for almost 400,000. We have about 2.5 million cases being reported every year. So about a fifth of them almost are because of undernutrition. So imagine if you were to get rid of undernutrition, you would automatically TB cases would come down dramatically. Alcohol is also playing a very big role. And the more I'm traveling in states, particularly in the southern states, I'm seeing that alcohol addiction is really interfering with TB management, then diabetes, smoking, and HIV. We've had a number of new initiatives announced by the government, including the BPAL-M regimen. That's a new regimen for multi-drug resistant TB. You can see that this was used to be the treatment. Every day, imagine taking all this tablets for 18 months. With the BPAL regimen, this is what you take for 6 months. So it's a massive relief for patients. But not only that, even after taking this, cure rate was 50%. Cure rate here is closer to 90%. So now this regimen is being rolled out countrywide, trainings have happened and so on, and it should become the standard of care. The other one is nutrition, because I mentioned undernutrition being a risk factor for TB. It is also a risk factor for poor outcomes. Once you have TB, if you're undernourished, your chances of dying and your chances of not responding to treatment are higher. So the government of India has now doubled the monthly direct benefit transfer. It used to be 500 rupees a month. It's gone to 1,000 rupees a month. And they've also announced that for malnourished TB patients, there'll be extra nutrition support, energy dense nutrition support, and for household contacts. Because what happens is that when the man of the house gets TB, he's out of work, the household suffers. And not only do they become undernourished, they also have a higher risk of TB. So by providing nutrition to them, you can prevent them also from the children and the other people living in the house. So that is right now being done through a voluntary kind of a mechanism. It's called a Nikshay Mitra program. You have to volunteer to support a TB patient. And the hope is that every TB patient who's needing it gets linked to somebody. But of course, it doesn't happen for all of them. Whereas this is a government program that from 500 going to 1,000 rupees a month. So at least now they can use that money for nutrition. Now, this was in Wayanad. Actually, I visited a home of a young woman who had died of TB. And I was wondering why in the state of Kerala should a young woman of 25, without any other major complications, why did she die? And what could have been done to prevent? Because, she's left behind two young children, and her husband, of course, has vanished. And this is her mother now looking after those two young children. So there are certain key populations, including tribals, but also, of course, other poor and marginalized. But particularly for tribals, I think we really need a different approach because of the dynamics between the health system and the tribal population. Maybe the care seeking is not timely. They have their own compulsions. Maybe the response from the health system is not as good. Um, they also are malnourished. You can see how thin she is, this mother. This woman was very anemic, I understand, the one who died, and maybe she had a delayed diagnosis. So there are initiatives in other states, like in Tamil Nadu. They have an initiative focused on reducing TB deaths. And they have made some progress because what they basically do is You just identify those who are at high risk. Somebody comes to you weighing 25 kilograms with TB, an adult, fully grown adult. You know that person is at high risk. If they are breathing rapidly, if they're not able to eat, if they are looking sick, you know that if you send them home and the home is like this, what will they get there? So you admit that type of person for a month and look after them in the hospital, give nutrition, give good clinical care, then discharge once they're better. So that kind of thing has been shown in Tamil Nadu and one or two other places to work. So I think we need a special focus on Kerala's tribal populations. That's where the problem of TB, undernutrition, anemia, all this is very common. Mental health and stigma, they remain neglected aspects of care. And this is Deepthi Chavan is one of the TB survivors from Bombay, who there are many such champions now who speak very articulately about what they've gone through and why they need to be involved, basically as well in the programming. Now we've got technology, we've got these mobile x-rays, which look like a camera. You can take them to the field, you can carry them in your backpack, take an x ray. Artificial intelligence will read it right away. Within 2 minutes, you can tell the person whether they have a suspicion of TB or not. And you can then do a confirmatory test. So, by doing that, you can pick up subclinical TB and increase the efficiency of screening. And the earlier you find people and treat them, you can reduce mortality. So, you can also take these mobile vans with x rays as well as the molecular tests. So, technology is definitely improving. And currently, we do have good tools for diagnosis. We need to make it available and accessible to everybody. And like I mentioned, most of the patients who die in the first 2 months, we look after them then. They should definitely improve. I'll switch to climate change and air pollution, which is one of the leading risk factors for health today. Both indoor and outdoor air pollution causes 1 out of 8 deaths in India indirectly are due to air pollution. So it's a very major risk factor. What we need is air shed management across state and even across country boundaries. As you saw during the winter months, the entire Indo-Gangetic plain is having very poor air quality. It's Pakistan, Nepal, Bangladesh, and many Indian states. It is, of course, a lot of it is because of the small particles, PM 2.5, but you also have other pollutants like ozone and methane and sulfur dioxide, nitrogen dioxide, black carbon, very bad for health. Causes a lot of diseases, not just in the lung, but affects the brain, affects many parts of the body. And of course, the sources of air pollution are the same as what are causing global warming and emission of greenhouse gases. So I'm part of this commission that director mentioned, Our Common Air, which is a global commission. It's basically a call to action. WHO standards are 5 micrograms per cubic meter. And generally, if you look at your city, I don't know what is Trivandrum. Normally, I see wherever I go, a board normally will have the PM 2.5 and PM 10 levels. I did not notice it here. But most of our cities are way above the WHO standard for good air quality. So it's an invisible health threat for all of us. And it needs a multi-sectoral action. It's not really the health department that can address the sources, but the health department or the health ministry has to be a champion. And there are solutions, across uh, transport and how you manage your transport, um, your industrial emissions and how strictly you regulate them, construction dust, roads, how good quality are your roads, and finally, indoor air pollution. Women who are still burning biomass. Moment you go into any of these tribal areas, you will see large parts of rural India, women are still using biomass because they can't afford the LPG refill. So, again, the solutions are there, but they need to be addressed across multiple sectors. Now, climate change is having a massive impact on our health. It's both through determinants and also impacting the systems. You can see here some of the vulnerability factors, which of course are your socio determinants of health. We have things like extreme weather events. We've all, seen now heat, flooding, sea level rise, with dengue because of mosquitoes now surviving for longer times of the year, going into new areas, water scarcity, and of course, it will also affect agriculture. And then when it comes to exposure, so your whether you're impacted or not depends not only on the hazard, but also on whether you're vulnerable and what is the exposure that you're having. So it will have multiple impacts, on both health outcomes, waterborne diseases, vector-borne, malnutrition, respiratory, heat, and on the health systems and the facilities. We have seen that health facilities also get flooded, or they don't have the capacity to deal with these crises. And it has a gendered impact. So, no, this graph just shows that more than 80% of Indian districts now are um, susceptible to some kind of climatic hazard. And if you add heat, then it becomes 100%. This is only for floods, droughts, and cyclones. So if you add heat, it is almost every district in India. So we did this report for the Women and Child Development Ministry. They wanted us to look at different agroecological zones, and we found that certainly women are disproportionately impacted, whether they are pregnant women with higher health risks, gender based violence, uh, threatening of livelihoods, access to water, access to fuel, children's health and education. And then we also found that we need more data, more research coming from different parts of the country, and also more solutions. So, some of the recommendations that we made is that you need now for climate change leadership at the highest level of government, because it has to involve all of government and all of society. You have a national action plan on climate change and a national action plan on climate change and human health need to be synergized between climate change adaptation and health system strengthening. We need heat mitigation plans at the local level, every gram panchayat and urban local body. And I feel it's time for a city heat officer to be appointed, at least in the big metros. We need a consistent definition of a heat wave, because temperature alone does not determine how much you're affected. Humidity, night temperature, all of this makes a difference as to how much the body is able to withstand. So the IMD is looking at. We need early warning systems, and we are working on some early warning systems with the Indian Institute of Science in Bangalore using artificial intelligence. Cities have to look at how they are going to design. They need to look at having many more blue green spaces, because otherwise the urban heat island effect increases the impact of heat in cities. We have to look at gender focal points and gender based budgeting, and vulnerable groups, young children, older people, pregnant women, and of course, disabled. These are all people who will be very vulnerable. Climate migrants, we have started seeing climate migrants, internal migrants from one district to another district within the state of Kerala is already happening. And of course, you get migrants coming from other states. Now, it's not that is a completely a bad thing, but if they are being forced to migrate because they can no longer survive, then that is a bad thing. And coastal cities are more likely now in the next few decades to experience the impacts of rising sea level. I talked about gender, and especially when you have emergency shelters, our study found that violence increases, that women really feel that they need much more, gender appropriate emergency shelters, toilets, menstrual health. All of these things are usually forgotten. I talked about AI and how we can leverage technology for early warning. Schools, many children are now suffering from what's called eco anxiety. And so you need to talk to children about climate change in a way that's not always depressing, but also, you know, some hope. Um, Mental health is a big issue. I'm not talking a lot of details today, but all surveys are showing that young people's mental health is in a very poor shape. And, many reasons for that started with COVID, but needs attention. And then we need more longitudinal studies, time use studies, particularly since time and effort that women dedicate uh, to things like collecting water, collecting firewood are not very well appreciated. So, looking ahead, where do we need to go now? So, as I mentioned, we are on this journey, and I think we, of course, need to do agenda setting and accountability. What are our structures? Who's empowered? Who's accountable? Comprehensive primary healthcare services. We need to localize, integrate, and expand services, invest in human resources for health, better use of data to inform our actions, and also enhance financing, of course. Private sector stewardship, I think for Kerala as well, this is a challenge. Um, how do you, provide that governance and stewardship of the private sector? They are going to be there, they are going to provide services. How do we manage them in a way that they contribute without being exploitative? I think we saw that during COVID and pandemic preparedness. I'll say a bit about that. This is Thailand, one example. I'm very always impressed with their primary healthcare model, their National Health Assembly, where it's basically people from every district coming together. So they have district level, state level, and national level health assembly. People are not only setting the agenda, but they're also following the policies to see if they're being implemented. They're doing the monitoring, evaluation, and the feedback. And I think that's how the community has a very good voice in the whole health policy process. The other thing, of course, is to look at health in all policies, like we mentioned earlier, not just health delivery, but how do you account for health across different government departments. This is an example. This is the Jan Arogya Samiti. It's like a same model of a gram, a village health and nutrition um, committee where they meet. You're supposed to have equal men and women, and the panchayat members are there. The sarpanch is there. You can invite special people. The PHC medical officer and other health professionals join in, and if you have a discussion, that's really a way of. But this is not happening everywhere. This is ideal. Should be happening, and if it does, it can really help to improve health services. And again, our frontline health workers are often burdened with too much of data collection and reporting. Um, and they need to be much more about delivering uh, family based and individual based health services. So that's what is integration. You go to the house for one thing, you ask about TB, and then you leave. It's an opportunity to look at a holistic, you know, family consultation. You may find out so many problems in that family, even if there's no TB there. But that doesn't happen because we still have a few vertical programs. We need, of course, better referrals from primary to secondary to tertiary hospitals. And if we had focused specialty hospitals, that is a model that's shown that if you have a hospital that's dedicated only to orthopedics or only to cardiac care or only to neurology, generally the quality is better. And you could then also refer people selectively to those places. And so that's not something that we've tried here, but I know that there's an experiment going on with intensive care, putting in place a 10-bedded intensive care for each district, to see if you can provide that. affordable and high quality care. Similarly, we need to look at determinants, nutrition, water, hygiene, indoor air pollution, and so on, and also now more and more care for the elderly and the disabled, and climate change adaptation. All of this has to be um, um, uh, planning needs to be done as we think about expanding our primary healthcare services. So this shows the doctors in blue and nurses in orange, the density per 10,000. So Kerala is right here at this extreme with the highest density, mostly nurses, and other states are behind. But even if you have doctors, they don't want to go into the rural area. So that's the problem. You have that unequal distribution between urban and rural. So we need to ideally redistribute, look at not just numbers, but where are they? And of course, I think this model where you have more nurses and mid-level providers than doctors may be the best way to approach primary healthcare today with the e-sanjeevani and digital outreach, uh, teleconsultations and so on. You can get specialists. So a lot of primary healthcare can be provided by this team that may not always have a doctor there, but is well trained and who's mentored continuously. So yeah, mentoring I mentioned through platforms like Echo. You can see them here. Many states now have a mentoring program for these mid-level health providers, and some states also have a physician assistant program. Data, as I said, these poor women are all the time spending, writing records. So we need to have a better way of sharing data between the different, uh, you know, line ministries between state and center, and having this kind of a common ID should help. We should really reduce, because also apps, each state is coming up with their own app for each program. So they really have to, at some point, all start talking to each other. Financing, this is health compared to other things, defense, etc. Mhm. So we need to increase that. And maybe it has to go to outcome, performance based allocation, particularly when you're reimbursing the private sector. We should think about really outcome based reimbursement so that you also reduce the unnecessary procedures and surgeries and so on. So PMJY is the insurance program works in places which have hospitals. If you don't have, then this model cannot work in remote areas, and so the public sector has to provide services. And then to monitor the private sector, we will have to implement the Clinical Establishment Act. Some states, notably Rajasthan, had gone in for a right to health law, but I think that's something to really consider. It makes, of course, then the commitment that state is making a big commitment, but it's a good way to go, just like right to food and so on. Now, on the pandemic preparedness, Kerala has already taken a few steps, I think, established their own virology lab. And now I understand the state CDC, Center for Disease Control, will be established. I was part of this expert group that produced a report for the Government of India on future pandemic preparedness. We essentially made recommendations under 4 pillars. Governance. So the first thing we said is we're still governed by an Epidemic Disease Act of 1897. We need to have a more modern public health management act, which will also include what happens during emergencies. Otherwise, we're again back to the disaster management agency, which is really was not set up to manage biological disasters like epidemics and pandemics. So that's the first thing: the governance, the legislation, the financing, and the management. The second bucket is around data management, surveillance, early warnings, forecasting, and modeling. And we need a good system nationally where high quality data is not only collected, but it is immediately analyzed and used at the local level. And so we need to test. We had outbreaks recently. We've had a Guillain-Barré syndrome outbreak in Pune. We had Chandipura outbreak in Gujarat. Periodically, of course, we get Nipah in Kerala, but each one is a opportunity to learn how well we're doing in terms of all of this. Then the third pillar is around supporting more research, innovation, manufacturing, infrastructure, and skilling. This is, also to get the private sector to do more work on diagnostics, on vaccines. Because what happened during COVID is because of all of the R&D that had been done earlier on other coronaviruses, certain groups were able to produce vaccine very quickly. But that cannot happen unless you have invested beforehand. So it's really important. And there are many, many viral families which can cause an outbreak. Influenza is the most likely, but it could be another corona. We don't know which virus family it will come from. We know the likely ones. So, can we actually prepare for that? And the last pillar is around community engagements, including risk communication. We know that, you know, states and countries which had good primary healthcare infrastructure, community health workers, good risk communication, good trust in government, they did much better. So, looking ahead, I think our challenges for the future is the increasing burden of non communicable diseases, including mental health, aging population, the inequities which still exist, the financing which is still inadequate, and climate change on top of all this. The solution, of course, we need universal health coverage, and to get there, we need all of this, including the comprehensive primary health care, regulating the private sector, making sure that we have put in place steps to make us resilient both to pandemics and to climate adaptation. In terms of Kerala, as I mentioned, of course, it's been a global pioneer. I think this institute has documented a lot of that, the Kerala model that's talked about in terms of health indicators. We see that in a lot of these, Kerala is much better than the average for India. And the new Public Health Act and setting up of some of the institutions, I think will go a long way. As far as I know, we don't have a public health cadre here, but maybe we can have a discussion as to the need for one. So, again, because also of strong local bodies, panchayats, and people's participation, it is much more possible to have good primary healthcare service delivery. Again, we have to focus on certain pockets which are falling behind. A public health cadre would be, I think, very, very appropriate. Focusing on prevention and health promotion, I think, is going to be key because you cannot keep on treating people, allowing them to develop diabetes and then treat them because it's just very expensive and it adds so much morbidity. So, the much better idea would be to prevent, which means understand the risk factors and address those. Not easy, but needs to be done. Increase care for the elderly, mental health, focusing on tribals, nutritional outcomes. What I mean is again increasing obesity and more investment in health research would be great. So I think I'm going to stop there and over to you if you want to have a discussion.
Thank you, Dr. Soumya Swaminathan, for that really very comprehensive. It's really an expert speaking on that field, 360-degree view of the all issues covering the entire health sector in India as well as globally. So, it highlighted all the challenges that we face in universal health coverage, low public health expenditure, high out-of-pocket expenditure, catastrophic expenditure, unequal access, poor quality of care, climate change-related issues, non-communicable disease burden going up, lack of preventive and primary care. So many issues have been covered. So I think this is a like any topic where a lot of questions would be there naturally among many of us, and I'll open it up for discussion. But before that, just one um, uh, question from my side. Like, in India, if you see our own performance of the government, Indian government, we see that if whenever we are in a mission on a mission mode, like for example, eradication of TB or polio or COVID, we did very well. We generally do very well on a mission mode. But when it comes to managing day-to-day affairs, many of the issues that have been discussed here, we lag behind very significantly. So that means there is a kind of this, to contrast. Like, we are very efficient when we need to do things on a mission mode, but other things we don't do it well. So generally, it leads to a lot of inequities, and the people who are at the receiving end are generally the poor and marginalized in that type of a system. In the mission mode, everybody is taken care of more or less. So that is one problem, and it is related to structural issues, more systematic and structural issues. Many of those things Dr. Swaminathan already mentioned, but there could be many more such structural issues which are standing in the way. uh, there could be many. One I thought is that this this shortage of professional healthcare in India. Like, it's something very striking. Like, the medical education in India is extremely costly, and that's why Indian students, they go to all kind of countries, for a medical education. We don't know whether they are coming back and practicing it in India. So there is a that is one big structural problem, that we don't have enough qualified professionals uh, uh, to take care of these things. So there could be many other structural problems, including insurance. Again, there it's a fragmented, like, the Ayushman Bharat scheme help when there is a inpatient kind of treatment when you are, but there is a huge outpatient treatment, and most of these catastrophic expenditure and all might be there. So there are several of those structural problems. I think that is where we need to really look at. I just open up with this, to the floor for questions.
Happy to hear comments as well, not just questions, but also some of the important issues, that Dr. Veeramani just raised. So it's aware of.
Process will.
Thank you, Dr. Swaminathan. It was a 360 degree perspective, as Professor Veeramani said. From the kind of big picture perspective, how would you characterize the larger policy trajectory, in the sense a lot of the story seems to be about a kind of solid health bureaucracy, which is conceiving these schemes. There's a kind of incremental progress that kind of comes out of this story, maybe at a national level. And it's not a political story, right? Right to health or Mohalla clinic. But it's never been so political, maybe in Kerala, in the way in which you meant. But for an all India perspective, the story seems to be not about the politics of development, but about a solid health bureaucracy, what's the literature calls a subsystem, where bureaucrats, experts, medical people, all these kind of think tanks coming together, maybe global, and pushing the story along. Would that be fair? And that seems it's not true in many other sectors, right? But is there something about health where this story that you're saying, it's not a story of politics? Uh, it's yeah, and even with the private sector coming and maybe complexities of regulation, But the impression I'm getting from this presentation is there's something solid about the bureaucracy, and not the bureaucracy, but that subsystem. Is there as much consensus there, or if you unpack it, is there a lot of kind of conflict there, more than maybe your presentation could, pitch? And also, relatedly, it's a very national story. I mean, do state governments have that kind of capacity to reimagine health policy? Are they largely policy takers rather than policy makers? Um, yeah. Yeah.
We'll take some more.
Then we could add that.
Hi, ma'am. Thank you for the talk. It was quite comprehensive. So my question is, I just wanted to see, how do you see India's policy focus on alternate medicine now? Basically, the recent push towards Ayush and all. I just want to hear your thoughts on that.
Okay, so maybe I can take these. So maybe take the Ayush one first. Yeah, I mean, I think there is a big push towards what's called integrative healthcare or integrative medicine. Because we've had this traditional systems like Ayurveda and Siddha, and those systems were really quite holistic in the sense that they did focus on prevention and health promotion in addition to treatment of diseases. So the idea is that at the primary care level, that there could be scope for learning and integrating from those systems into healthcare delivery. In practice, it has not been as so easy. And one of the reasons is because, unlike the Chinese system, where allopathic medical students are taught about the Chinese traditional system and vice versa. And from the beginning, the approach is to use both, to refer one to the other. They understand where you have strengths and where you may not, each system. And so it works much better there. Whereas here you have these two parallel systems. Allopathic training, you're really not told anything about the traditional systems, and vice versa. So it becomes very difficult later on to integrate. We also need, in today's world, an evidence based approach. And so while our traditional systems are more experiential and word of mouth coming down from many, many years, today's medicine demands that there should be an evidence before we put it into practice. So I think now that there is good collaboration between Ayush and say the ICMR and so on in doing those joint programs, evaluating the impact. And I think Sri Chitra has been one of the institutes, right, to be doing that over here. But we need more of that and also more implementation research into how do you. So if a patient goes to the PHC and they are told you can go to a Siddha doctor or a homeopathic doctor or an allopathic doctor, it's very difficult for that person. But if the doctor who sees then says that, for this ailment, we don't have a cure, we have symptomatic treatment, we can alleviate your pain, or you could also try Ayurveda that might help you, for chronic diseases. But make sure that, like diabetes, you can't completely say now you go off to Ayurveda and I won't see you again, right? Because you have to monitor the blood sugar, you have to make sure that things are under control. And so it's a difficult one, but I think that's where the aim is, as far as I can see, to get to a place where we can have a true integrated system. Your, I think, observations, yeah, I think quite profound. And the fact that, yes, it hasn't been, health has not been a big factor in, I mean, for example, in election manifestos, except for a few exceptions. The demand for health has not been, very high up on the political demands as well. I mean, I think I was reading articles before the recent elections in Delhi as to why air pollution was not on the agenda of any political party, and why was the population not demanding it, considering that everyone is suffering the impacts of air pollution? So, I think, yeah, um, in many parts of the country, also, I find that people are not aware, they're not demanding, that they don't know that, what health services they're supposed to get, etc. Kerala is very different. So we can't extrapolate. But the other part of your question, I think, is also very important about the capacity of state governments. For example, health technology assessment today is used for priority setting, as well as for decisions on which technology or which drug or strategy you want to adopt if you have a choice, and cost effectiveness analyses, both efficacy analyses and cost effectiveness, makes it easier for a policymaker to make that decision. So this was something that we started in 2016, and today it has grown. There's a lot more health technology assessment happening in the country, but we need to get to the point where every state has the capacity. Today, the health secretary here wants to roll out, let's say, HPV vaccination, or he wants to roll out some, treatment for a rare disease, which might be quite expensive. He needs some of this kind of analysis to help him make that call. And because the finances will always be limited, and you're always having to choose, so you have to make a choice based on something. Similarly, I think I have seen in Thailand, for example, they have an institute for health promotion and prevention. And that institute actually is funded by the tax on tobacco, alcohol, and now also on high sugar beverages. And they make policies on health promotion and prevention. It could be road safety, it could be things around, wearing helmets on tobacco. But to have a group who does that. So I think public health is something which is a specialization of its own. It's not something that every medical doctor can do or is trained. So this is why a public health cadre becomes very important. People who are trained to think differently. So if you put a clinician in charge of public health, they'll have a limited or a different view than putting somebody who's trained on public health. So this is why I think every state in India does need to develop these institutions to be able to, for us to go to the next level. Because one, as you said, driven by policies coming from Delhi, by a group of people, will may be okay for to some extent, but beyond that, that the context and the differences and the needs of the states are very different.
Yeah. It's okay. Speak after.
Yeah, okay. So, during, thank you very much, ma'am, for very interesting lecture. Uh, During the COVID time, one of the issues, among the many issues, was a large number of people refusing to take vaccines. There was a lot of vaccine resistance that was there, and that has not died. In fact, it has spread to other diseases also now. Many people are having vaccine resistance. That's one issue. The other issue is that along with vaccine resistance, there is a larger number of people who are refusing to take antibiotics and even regular medicines also. Right? So there is an issue about what we understood, or what generally we understood as medically good. I don't know what is the other term to use, medically good. And there is this discourse that is actually narrative that is developing. What is good or what is not, or what is medically not good or not bad, right? So isn't it part of the public policy, or what we call as public education, at least health education at least, that how to understand what is good, what is bad, what is medically good, what is medically bad? I think that's also becoming an important medical issue, because most of them, there is an increase, especially among the younger people also, that there is an increasing resistance to this thing. So I would like to hear your comments on this.
No, very good point. And I mentioned the misinformation and disinformation, especially through social media, that played a big role in COVID and continues to play a role. And the use of AI and all kinds of technologies today, which actually a lot of people get their information, unfortunately, today from looking at either social media or even at WhatsApp, right? Forwards. And misinformation spreads much more faster. So there's no very good answer to this, but I think the way to counter it is for the health authorities. Essentially, government has to take responsibility for this. They should be the final go-to point and the point of trust for people. When the government authorities say something, it should be the final point of truth. Should communicate much more um, regularly and about different topics. So in WHO, for example, we had something called social listening. We started that during COVID, where our communications department would be monitoring social media, and they would come to me and say, okay, this week there's a lot of conversations around vaccines and infertility happening on Facebook. Or next week, there is something going on some other topic. Of course, a lot of it was vaccine related, but then we branched into other areas and we started many different communication new methods, like something called Science in Five. So, a 5-minute video where either me as a chief scientist or any other expert from WHO would be talking to one of our communications persons about a topic. So, she will ask a question. Do COVID vaccines cause infertility? What do we know about it? What is the scientific facts that are known? Could be a lot which is unknown also. We should always talk about what is not known or what needs to be studied and give a factual account of the that particular subject. So that was one example of Science in Five, but we of course had a lot of press conferences and things like that. So you have to build up the trust, you have to be visible, you have to be seen, you have to agree to be also transparent with data, you have to many times you have to agree that you were wrong and that you have changed because of new evidence that has come in. That's all part of science communication, which nobody is taught. And some of us had to do it during COVID, some have done it before and after, but it's a skill. And this whole infodemic, the word infodemic, which we used to use during COVID, is, I think, here to stay. People will be confused, and especially when you have a population with low health literacy, low science literacy, it is very easy to mislead. So this requires a long-term effort, has to be led, I think, by government, but could be also good science communicators. So I always, when I go to scientific institutions, I say we have responsibility as scientists to communicate in simple language what we're doing and not talk down to people, because as scientists, sometimes you talk a lot of jargon. People get put off by that, you know. So even during COVID, we had to be very careful as to how we answered questions, not to be defensive or to be superior or to say, oh, you're a foolish person to say things like that, but treat that question with respect and answer. But despite all that, I think this is a very challenging area, and there's a lot of work now I've heard of that even talks about digital vaccines. How do you vaccinate children uh, to not believe everything that they're seeing on, because kids growing up today are growing up in a virtual world, and they need to be able to distinguish finally what could be right and what could be false. But there's no good answer for that. But I think public health communications skills and people working on it has to increase tremendously if we want to improve the health literacy and health behaviors. Even something as simple as nutrition, I think, people are just not aware. And a lot of it is being driven by celebrity endorsements or celebrities saying this is good for you or that is good for you. May or may not be true most of the time, not true. So the scientists are not there. The real nutritionists are not talking. This is a problem. India had less vaccine hesitancy than many countries. So I think we were relatively lucky. Yes, in pockets there was. But if you look like the United States, there was 50% of the population did not want to take the vaccine.
Devika Prasad.
Sister, here with on this question is what is striking about vaccine, these people who resist vaccines are not exactly, literacy of poor literacy. In fact, it is the other way around. They are often much exposed to all kinds of ideas, including great distrust of the state. There is a growing distrust of the state. There is this belief that the state is closely entwined with, and it is ceding more and more space to capitalism in managing health. So that is very much there. In Kerala's case, I think a lot of it was actually tackled by the ground level ASHA workers. Hmm? And I really want to ask you, I'm so glad that you brought up the ASHAs in your presentation. I'm really thankful to you for that. I know everywhere in India, we are seeing ASHA workers on strike. They are among the poorest paid in India. And as we all know, this is an old, it's an old method of the state to employ volunteers at the bottom level and pay them an honorarium, do not accept them as workers. For how long can we afford continue to do this? As you rightly mentioned, there are so many challenges lying ahead. So, in your estimation, what would you say? How long can states afford to underpay and overwork these women at the bottom?
So I think just in today or yesterday's paper, I read that their incentives have been increased. So that is something. But yeah, I agree with you that ASHAs must be well compensated. Our frontline health workers, they're amazing actually. Most of the ASHAs I've met are so dedicated, so motivated. They're doing it much more, because of the non-monetary benefits they get, respect and things like that. But yes, they must be compensated properly. And I think we need a whole discussion on human resources for health for India for the future. What kind of people do we need? How many do we need? Where do we need? It's not only about doctors, it's about a host of others. And they are actually more important. You need, in the future, you're going to need physiotherapists, rehabilitation experts, palliative care people, of course, nurses. You need people in the community. You need uh, lab technicians. So I'm not sure that we've done that exercise, at the state or the national level, and then a planning for how one would train and equip, and then, of course, pay these people. But if we want good health, then I think that is the way. And primary healthcare focused growth, you know, we need to really focus, make sure that we're doing that, because the tertiary hospitals can are needed to treat people who are sick, but you have to prevent them from getting that seriously ill by dealing with issues when they are still not complicated enough. So today the dialysis rates are going up, up, up because hypertension is not being identified and managed appropriately. And the figures, surveys show that hardly 10 to 15% of people who have high blood pressure have it under control. Majority of them don't know it, and those who know it are not on the right treatment or are not regular with treatment. So those are the kind of challenges that only a strong primary healthcare service can actually deploy. And again, we will need to tweak. For urban, it'll have to be a little different. For tribal, it'll have to be a bit different. The hamlets are so far that one ASHA may not be able to cover. I know in Kerala, I think there's a second ASHA for tribal districts, but not everywhere.
Thank you.
One question I have is sort of borders on trivia, which you have already answered. How does it happen in affluent societies, supposedly intelligent people, become so easily victims of the disinformation campaign? And you answered it saying that one can request conveying it with the scientific services of the scientific community. Well taken, I'm not going with that. But then the other point you drew attention to, so that the demographic environment.
which is what really is doing the investment in healthcare, and the other 25%, which is due to the extension investment. I believe it's in that 25% is that the crucial shortage still remains. As you pointed out, we have something like 2% of the GDP being spent on, which is an abysmally low proportion. And with such pragmatically low levels of expenditure, how on earth are we on earth will we make any progress in this continuing journey? A second question, this huge urban bias to the extension of care services right now as it stands, because urban hospitals, mostly under the care of the private sector, are the major providers of healthcare. There is a problem about that. It really adds to the cost. As you know, the out-of-pocket expenditure, everything. But then the answer is the state presence as a countervailing force, which can possibly bring down the cost of healthcare. And again, my question is, how long will it take for us to do that kind of compensating variation with active intervention of the state? Thank you.
I wish I could answer those questions. I don't have a crystal ball. So, I mean, that's the direction we absolutely need to go in. Financing has to increase. The human resources for health have to increase. People's participation in health has to increase. Our communication ability has to increase. We need a lot more research, behavioral science research as well, which is not happening currently, as to what drives this type of behavior and how do you begin to address this new era that we live in, of misinformation. I think you need a lot of social and behavioral research to understand what is driving. Like everyone said, people are highly educated and yet believe in conspiracy theories. So I meet a lot of people who are convinced with conspiracy theories around COVID and around vaccines. So I don't have, the answers, but you're raising obviously the very important questions.
Thank you so much, Dr. Soumya Swaminathan. It's a very enriching and informative discussion. We all learned a lot. So thank you so much for sparing your time. Thank you.
Thank you very much. Thank you.